Hi and welcome to the Nurse Station. I'm Maria Mobley and today we are going to learn about complications associated with diabetes mellitus. As always, these videos are for educational purposes. I really hope they're helping you all. And if you didn't check out my video about introduction to diabetes and the pathophysiology along with patient education, please do so before we get into the complications of diabetes. So, you all are going to take care of many diabetic clients, and it's essential to understand first off how we treat diabetes, which we talked about in the first video, but also how to catch complications early and intervene quickly to try to assist them and promote optimal outcomes. So I've listed complications, and on the back of the board we'll get to DKA and HHS, which are the hyperglycemic complications. But first, we're going to start with hypoglycemia. I need you future nurses to understand, if the blood glucose goes less than 70, you need to act, and you need to act right now. You don't need to gather any more data. You don't need to assess. You need to get a simple carbohydrate in them. And so when you think about carbohydrates, you think about sugars and starches, right? A simple carbohydrate breaks down very quickly into energy. So pretty much just give them sugar. So if you walk in there and let's say you have a diabetic client, let's say they went to a CT scan or MRI and you come back and they could have missed their breakfast tray, and you all of a sudden notice that they're sweating and maybe they have a headache or maybe they're really irritable. Those are all potential signs of hypoglycemia. I listed a couple signs for you: diaphoresis, change in behavior, tachycardia, palpitations, headache, slurred speech. Hypoglycemia is a very serious condition. It can lead to seizures. It can lead to a comatose state. However, remember, you walk in that room, we can't act unless we absolutely know the problem. So you walk in the room and they have a headache and they're sweaty and they're angry. They could just be mad that they missed their breakfast tray. So remember, we always have to do ADPI. We have to start with assessment. Well, that assessment data isn't enough information for us to go ahead and give them sugar. So we need that objective, sure information that's telling us it's hypoglycemia. So if you see any of those concerns, you need to get a finger stick very quickly. And if that finger stick result shows you that the glucose level is less than 70 milligrams per deciliter, you need to act. If it's 69, you need to act. So critically thinking, because this is true in the real world, but remember, I also gear you to test according to the NCLEX perfect world. Critically thinking what type of sugar or simple carbohydrate you're going to give them is related to their responsiveness, okay? So think about it. You walk in the room and they're difficult to arouse. Should we put anything into their mouth? Absolutely not. What risk does that create? What safety implication does that create? If they have a change in behavior, if they're difficult to arouse, if they are confused or have slurred speech, we put something in their mouth, that could be an aspiration risk. So I really want you to think, if there's any change in behavior, if there's any change in level of consciousness, you do not need to be putting oral medications into their mouth, because we could be doing harm if they vomit and they can't control it and it gets down into their airway, okay? So just think, the medication we administer priority-wise is related to responsiveness. Yes, you can and do need to know your facility protocols. You could have a client with a glucose level in the 30s and they look absolutely fine. Yes, most likely, if they look absolutely fine, they're responding, you could give them oral medication, but that glucose is so low, you might need to be giving them D5W, okay? I'm sorry, D50W, which we'll talk about in terms of treatment in 1 second. So, let's think. Walk in the room, we saw concerns of hypoglycemia, and remember, know all the symptoms that your instructor gives you for testing purposes. That's just a few of the many signs of hypoglycemia. We get that blood glucose finger stick, and it's less than 70. You need to act. If it's in the 60s, they're responsive, let's get them an oral, simple carbohydrate, or we can just say sugar, quickly. A lot of times you'll see us run and go get orange juice, or we'll run and get a Coke. But remember, if it's a Coke, it needs to not be diet. We need sugar, okay? Diet Cokes and the diet sodas have all the artificial sweeteners in it. No, we need real sugar. So again, critically thinking, your intervention or what we give for hypoglycemia, dependent on responsiveness. If they are responsive, we can give oral entities that will give them sugar quickly. A lot of times you see us grab a Coke or a juice. We have glucose tabs available. We have glucose gel available. So we can give an oral simple carbohydrate or just give them sugar orally, okay? If they're unresponsive or a change in behavior, a decreased level of consciousness, don't put anything in their mouth. That topic, anytime there's a change in behavior, decreased level of consciousness, you always have an aspiration risk. We can't say it's airway because they're not choking right here, right now, but you better think safety. Remember back to my Maslow's video, any risk of physical can actually turn into a safety problem, so you need to keep them safe, okay? So what we typically do is give 50% dextrose. It usually comes in this 50 ml syringe, and you can hook it straight up to their IV access or their line access and push it in. It's very sticky, it's very hard to push. You really want to watch that IV site and make sure that it's not infiltrating, but we can give that directly into their circulatory system. We can give glucagon as well. Maybe they're difficult to get access on. We can give them an IM injection of glucagon. And this is just few of the many interventions that we have for hypoglycemia. So of course, gear it towards your instructor, but critically thinking, their responsiveness will determine if you can give something by mouth or if you need to stick to a parenteral route, okay? If we need to stick to an IV route or an IM route, all right? And then again, also, if their glucose is extremely low, even if they are responsive, we might need to give them intravenous intervention just to get those levels up quickly, okay? So once we intervene with our medications or with our Coke or juice, you need to be checking that blood sugar. Most facility protocols say Q15 minutes until we get it back to an appropriate level. And I also didn't write up here, but these are simple carbohydrates. They break down very quickly for the body to utilize energy, to utilize the glucose. However, once we get that glucose back above 70, a lot of times you see us giving a complex carbohydrate. A lot of times we're going to give them maybe a starch or a sugar in a starch so it doesn't break down as quickly and kind of keeps their glucose evened out inside their body, okay? So you can see us give them graham crackers with peanut butter or a peanut butter sandwich or something like that to just maintain those glucose levels so they don't go back into rebound hypoglycemia when that fast sugar breaks down really quickly, okay? So hypoglycemia, future nurses, you act and you act immediately. If that level is 69, you need to be doing something. And I need you to know your facilities and protocols when you get to the site that you'll work at. It will tell you what, depending on responsiveness, what you could administer. It'll tell you how often to check their glucose levels after that hypoglycemic episode. But in the NCLEX perfect world, a blood glucose level of less than 70, you don't gather any more data, you act, and you're going to intervene by giving them glucose of some form. And remember, it's dependent on their responsiveness, because if they are unresponsive or have a change of level of consciousness, change of behavior, do not put anything in their mouth, okay? So let's move on to decreased perfusion. I want you to think about glucose. Remember, with the lack of insulin or insulin resistance, we have glucose sitting in our blood and it's not being transported into our cells where we want it to be stored, okay? Or being transported into our liver, which is a primary organ of storage for glucose. So if all that glucose is sitting in our blood, think about your blood vessels, your veins, your arteries, all right? Glucose is sticky, right? Can't a lot of glucose start to adhere to the lumen of the vessels? So if we have a lot of glucose adhering to the lumen of your vessels, it's very similar to plaque or cholesterol. And is this making it narrowed? Is it leading to decreased oxygen perfusing through your vessels, right? Because think, your arteries is what supplies all your oxygenated blood to your cells, to your tissues, to your organs. So if we have decreased oxygenated blood to everywhere, or to certain sites, that could lead to your perfusion complications. So we split it up into macrovascular, macro meaning larger blood vessels, and micro meaning smaller blood vessels, okay? Let's just look at a couple of our macrovascular complications. Coronary artery disease. So that means this vessel is supplying the oxygen to my heart. Now I start to have all this glucose buildup, and of course you could have plaque and cholesterol buildup as well, depending on their diet, depending on if they are overweight, depending on if they have a lack of physical activity in their lifestyles. So decreased oxygen to my heart muscle, what could that lead to? I listed coronary artery disease, but diabetic clients have an increased risk of heart attack, okay? Hypertension. Your vessels, right? The more narrowed they are, isn't it more pressure trying to force our blood through? Can absolutely lead to high blood pressure. Stroke. What if this vessel was your cerebral artery? What if it's having a lack of perfusion to our brain? That could lead to a stroke. What if this vessel is now going to our lower extremities? That could lead to your peripheral vascular diseases, your peripheral arterial disease, or your peripheral venous disease. I have a really good video on that if y'all want to check it out as well. But just think, macrovascular, our bigger blood vessels, our arteries supplying our lower extremities, our heart, our brain, they're starting to get built up with glucose, among other things, leading to decreased perfusion. So with diabetic clients, if they start complaining about chest pain, you better start working them up for a heart attack. If they start complaining, let's say that you walk in and they have slurred speech, they have left-sided weakness, we need to intervene quickly to treat them for stroke and to start ruling out and doing our NIH stroke scale and all those things, getting them to a diagnostic study to determine are they having a stroke or not. So you need to look for these complications. If they're complaining or if you assess any signs of decreased perfusion dependent on where the perfusion problem is, you need to intervene quickly. And again, diabetes could be placed in multiple sites in your curriculum. You might not have gotten a heart attack or stroke, but just know if their baseline changes and they have a difference in their cognition, or they have chest pain, or let's say they have a decreased sensation to their legs and their pulses are weak, that is not normal. We need to start assessing and gathering more data and figuring out what the problem is so we can help them as quickly as possible. And then we got our microvascular complications. You need to think your small blood vessels. So I put nephropathy first. Nephro, you should always think kidneys. So a lot of times students think that the kidneys are supplied by big arteries like our heart or our brain. They're actually supplied by capillaries, which are very small blood vessels, because you got your veins, your arteries, and your capillaries. So nephropathy or kidney problems actually falls under microvascular complications because the capillaries are what are perfusing the kidneys. Then you have your retinopathy, your visual changes that can occur with diabetic clients. And then our neuropathy. When we think neuropathy, we should think nerves, right? We could have decreased perfusion to nerves. We could have nerve damage. So a lot of diabetic clients with neuropathy, they have that numbness and tingling. They have that decreased sensation. So is it safe to put a heating pad on a diabetic client's feet or legs? Not in this NCLEX perfect world. It's not even really in the real world because there's a risk of burns. There's a risk that they cannot feel when that heating pad gets too hot. Diabetic clients, we say, always wear shoes, always wear sturdy shoes, wear white socks, even when they're in the house, because if they have neuropathy, if they cut their foot, they might not even realize it. They might not even feel it. So we really got to protect their feet. We're educating them to get annual eye exams and to report any changes in vision really very quickly. With your kidneys, let's think, critically thinking, how many mLs of urine output do you need per hour to say that you have healthy kidney function? They need to make sure they're peeing. We need 30 mLs of urine output per hour. They need to report changes in urination. They need to report a decrease in urination, They need to report weight gain or swelling if they're not excreting their urine appropriately. So these are all complications that we need to look for, and we need to catch them early. And another complication we need to think about related to decreased perfusion is skin. Again, if you have decreased oxygen circulating to the skin related to all that glucose or plaque or cholesterol buildup, it could lead to poor wound healing. So if a diabetic client does get a cut, let's say on their leg, it could heal much more slowly, and it can dramatically increase the risk of infection. So really educating the clients to protect themselves, always again wearing sturdy shoes and socks, making sure to do thorough feet inspections and skin inspections to see if any cut or ulceration has developed, and to really report signs and symptoms of infection quickly. Yes, from the wound itself if they have a pre-existing wound, but also systemic signs if they're getting fevers, chills, if their white blood cell count is elevated. We really want to protect their skin, keep it well lotioned, keep them well hydrated, do thorough skin assessments, and if they have any pre-existing wounds, really monitoring them for infection. Again, going all the way back to decreased perfusion. So the last complications we're going to talk about are your complications related to hyperglycemia, elevated blood glucose levels. So hyperosmolar hyperglycemic syndrome, that's HHS. I didn't have enough room to write the abbreviation, but HHS versus diabetic ketoacidosis, DKA. So these are life-threatening conditions, and I'm really going to gear you towards the NCLEX perfect world, because as future nurses, I feel for y'all. That NCLEX is crazy. It's giving you 4 right answers, and I'm sure you get frustrated with your teachers like my students get with me. They're like, Ms. Mobley, it's right. We know it's right. It just might not be the best. Remember, 4 good answers, we have to gear y'all to getting to picking the one answer choice that you know when you walked in, you did this, and then you left the room and you kept them the safest and breathing or alive the best you could. So I'm really going to gear you towards answering those type of questions when you see HHS and DKA. So you're going to see this red squiggly line. HHS and DKA present very similarly, and then there's this one big difference between the 2 disorders that I'm going to talk about below the line, okay? So let's start. Both related to hyperglycemia, elevated glucose levels. So their glucose levels could be in the 400s, 500s, 600s. I've seen the glucometer, the finger sticks, not able to read glucose levels for these clients because they're so high. So remember, we always have serum levels we can draw and send to lab to get accurate glucose levels if the finger stick isn't reading. So extremely elevated glucose levels. And if you remember from my first video in the patho of diabetes, your kidneys are going to kick in. And when I say let's just pretend we're a diabetic client. Your kidneys are going to kick in. It's going to help you cope, and it's going to start peeing off glucose, right? Because our glucose levels in our blood are getting too high. Our kidneys, again, are going to help pee off those excess glucose in our blood. However, what follows it? Water. So you're polyuria. And then you get thirsty, polydipsia, because you're losing a lot of fluid. And then your body is still triggering you to eat because the energy is not being stored where we want it to be stored. Your glucose is not in your cells. So your body's going to keep wanting to eat and eat to try to get that energy that your body's starving for. But the P we're going to focus on is polyuria, because when we have such excess glucose levels and that dramatic amount of urination, it's going to lead to dehydration. So your priority for HHS and DKA is circulation. And remember, you will have data to support this. You need to look at their physical assessment. Yes, they have a high glucose level. Hyperglycemia is important, but if you see signs of dehydration, you see a low blood pressure, so low blood volume, and now their heart rate's getting high because the heart's just trying to pump whatever fluid is left in the body. You see dry mucous membranes. You see signs of decreased perfusion. Think about it. When we're dehydrated, the oxygen that is circulating in our blood, and remember it's lower blood volume, where will our body try to cope? Where will it try to shoot it to? It will shunt it to our vital organs. our heart, our lung, and our brain, right? And our kidneys is not going to be perfused as effectively. So you're going to start to see the BUN and creatinine levels elevate. So you need to be looking, clients with elevated glucose levels, you need to be looking for signs and symptoms of dehydration. And remember, in the NCLEX style questions, it gives you your question. If you see data that shows dehydration, your priority now is circulation. Hyperglycemia does not trump circulation in Maslow's. So yes, will we give these clients insulin? Absolutely. I talk about how we give IV regular insulin. However, if you can do one thing and one thing only for HHS and DKA, their glucose is elevated and now they're showing signs of dehydration because of that excess polyuria, you need to give fluids. Fluids is your priority intervention because, again, circulation trumps hyperglycemia in Maslow's. So, administer fluids, because you could have 4 answers. Give fluids, give IV insulin, assess vital signs, assess urine output. You could have all those answers, and we do all of those answers in the real world. That's why it's so frustrating, these NCLEX style questions. However, think, if I can do one thing and one thing only, HHS and DKA clients are going to die from circulatory collapse. Their fluid volume is going to get so low that they could go into shock and die from that. So we are going to replace that lost volume. That is your priority. So administer fluids on both sides. The type of fluids we always start with or primarily start with are isotonic fluids. So your 0.9% sodium chloride. We don't want fluid shifts. If we have a peripheral IV and we give an isotonic fluid, it stays in our circulatory system. It stays in our intravascular space. And that's where our depleted volume is. So that's where we want the fluid to stay. So we give our isotonic solutions. 0.9% sodium chloride is very typical. You may see lactated ringer, but isotonic solutions to start with to replace that volume. You will administer insulin, and this is not the time to administer subcutaneous insulin. This is the time to give intravenous insulin to try to get those glucose levels down much quicker. And the only IV insulin that we have available is regular. That is your short-acting insulin when you go back to pharmacology, and we will be putting it on a pump and infusing it via a pump to these clients, okay? Now, let's talk about the differences between HHS and DKA. So remember, both showing signs of dehydration, both administering fluids, both giving IV regular insulin. But let's talk about the difference in the body. On this side, HHS, the client still had some insulin prior to treatment, okay? So if they had some insulin in their body, there was still some glucose being transported into cells for energy, or being stored for energy, and glucose being utilized for energy. So, because there was some insulin in their body prior to treatment, they did not have ketone development. Ketones are an acid, and ketones are a byproduct of metabolism of certain sources, such as muscle and fat cells. So when we break down these cells that we don't want to break down, ketones, which is the acid, develops. Well, there is no ketone development on this side. So, is your acid-base imbalance affected? No. Their pH should be normal. Their bicarbonate levels should be normal. Their electrolytes should be minimally affected. If they're dehydrated, they could show signs of hypernatremia, but again, their electrolytes should be minimally affected because acid-base imbalances are not occurring. If you go back to my introduction to acid-base imbalances, remember, potassium is a really big electrolyte that's affected when we have acid-base imbalances. And because the pH should be normal, the bicarbonate levels should be normal, we're not going to see electrolyte disturbances that you would see when we talk about DKA, okay? So on this side, they do not go into an acid-base imbalance. ABG should be normal. They should not be showing signs of coping for acid-base imbalances, such as Kussmaul's or shifting of potassium. So, again, acid-base is normal, no ketone development. Let's talk about DKA. DKA clients, type 1 diabetic clients, are a primary example. Remember from my first video, I talked about instances where glucose can get elevated, infection. A diabetic client that is sick is a prime example of when glucose levels can skyrocket. Let's say this type 1 diabetic got sick. Let's say they reduced their amount of insulin for that day, or maybe didn't take it because they're not eating. But their body has no insulin. Their beta cells are destroyed. They're not secreting insulin. So these clients had no insulin in their body, or minimal to no insulin in their body prior to treatment. Are their cells starving for energy? Absolutely. Will certain products such as fat and muscle cells start to break down because the body's starving for energy? Absolutely. And once these cells start to break down, that's when you get ketone formation. So in DKA, and think it's called diabetic ketoacidosis, which ketones are acid, so it is increased acid in the body. So because the client is starving for energy and the body had to cope, and it started breaking down fat and muscle cells, leading to ketones, which are acids. Now we have increased acids in our body. What is going to happen to our pH? Normal pH is 7.35 to 7.45. If it gets less than 7.35, isn't it more acidic? So because of the increased acid, because of positive urine and serum ketones, our pH is going to start to decrease. In DKA, their pH can be less than 7.3 because they're in acidic state from this ketone formation. Their bicarbonate could be low, less than or equal to 18, because bicarbonate is your base and they're in an acidic state. Okay? And let's think about the acidic state that will occur. For it to be a respiratory disorder, they have to have a breathing problem. This is not a breathing problem. This is the body breaking down products that it shouldn't be because it needs energy, not a breathing problem. So the disorder that DKA clients go into is metabolic acidosis. And let's think about how our body copes. And remember to review the acid-base imbalances videos if you can't remember. The body is going to cope. The buffer system is going to kick in, right? And potassium is going to start to be pulled to the outside into the blood, so hydrogen ion, which is an acid, can go into the cell. So metabolic acidosis, these clients could have hyperkalemia. Let's think, the lungs can kick in next, and the lungs control CO2, which is an acid. So we're in this acidic state. Are your lungs going to try to blow off the acid, or is your breathing going to become shallow and try to retain the acid? Your lungs are going to try to get rid of acid as a coping mechanism. So these clients will have Kussmaul's respirations, a coping mechanism to try to get rid of CO2, which is an acid, because it's trying to help this acidic state right now. So you're going to see very deep, rapid, labored breathing, Kussmaul's respirations, okay? And again, your body's just trying to help you to get off acid. And then let's think about what additional interventions we might need. Anytime you have hyperkalemia or changes in potassium levels, you're at risk for cardiac dysrhythmias. So they would need to have EKG monitoring. We would need to give medication to try to reduce those potassium levels. You could see the great thing about insulin is it actually pushes potassium back into the cell, which is where we want majority of our potassium, decreasing your blood potassium levels. So that can help with your potassium levels. We might have to give other medications that would help reduce potassium levels. We need to look at those ABGs and see, are our interventions improving this metabolic acidosis state? So with our interventions, is our pH raising and getting back to the normal 7.35 to 7.45 level? Is our bicarbonate levels increasing to try to get back to the normal levels? So with DKA, the primary difference versus HHS is they are now in an acid-base imbalance. And you have to think about all those symptoms that come with the acid-base imbalance. Kussmaul's, changes in pH, changes in bicarbonate levels. They have this fruity ketone breath, okay, that can occur. And we'd additionally add on EKG monitoring, maybe medications to reduce potassium levels. In very severe cases, we can administer sodium bicarbonate to increase our base to try to help the acidic state. So other interventions that are necessary because now they're in an acid-base imbalance. And at the end of the day, whatever interventions you do, HHS versus DKA, you need to evaluate, did they work? And also, did your treatment cause additional problems? Remember, what is your priority for both? If you can do one thing and one thing only, they die from circulation. So your priority intervention is to replace volume. give them isotonic fluids, okay? They have hyperglycemia, so we're administering IV regular insulin. When we start getting those insulin levels down to appropriate levels, we can then convert them or transfer them over to a subcutaneous administration of insulin. But on both sides, massive bolusing of fluids, when you're evaluating if your intervention worked, we should see decreased signs of dehydration. That blood pressure should start to come up. Their mucous membranes should start to become peak and moist. If they had a change in level of consciousness or change in behavior that can occur with dehydration, you need to see better responsiveness, an improved level of awareness or level of orientation. But we could have given so many fluids that we threw them into fluid volume overload. So look for that complication as well when you're evaluating. Do you start to see JVD? When you're auscultating their lungs, are there any signs of crackles or fluid volume overload? So look for those complications. Also, when we're giving IV regular insulin, we can decrease insulin levels very quickly. You also need to ensure that we're not decreasing them too quickly, that we don't throw them into hypoglycemia, so risk of hypoglycemia. And over here you see risk of fluid volume overload and risk of decreased blood glucose or hypoglycemia. I just didn't have enough room to write it out. And then more so on this side, both with treatment, you could have risk of fluid volume overload, risk of hypoglycemia, because anytime we treat, we can throw them into the opposite disorder. And now more specifically to this side, we need to be evaluating not just circulation, don't just look at vital signs, urine output, mucous membranes, your physical assessment. You still need to be looking at ABG disorders or imbalances. So this side, you need to make sure that you're monitoring their ABGs. You need to make sure you're looking at the EKG, make sure that they don't have dysrhythmias related to imbalances in potassium, okay? And anytime we're giving medication to treat hyperkalemia, you could also increase the risk of hypokalemia related to treatment. So look for all those problems that can occur even with treatment, because that's a good nurse. You don't just intervene at the problem that's occurring. You're evaluating to make sure that your interventions are working and also that those interventions aren't causing additional problems, okay? So I really hope this helped you. I hope I kept it pretty simple, basic, to the point. And as always, y'all are the future. Y'all are the future nurses. Make it better together. So if this helped you, please grab a friend, grab another student in your class and help them so they can be successful on their test as well. As always, take care.